When I think about things that are similar or different between chronic pain and other medical conditions, I always fall back on the same principle. And I call it the Coumadin Analogy. I think that people often consider the things that they need to do to make opioid prescribing, for example, safe and effective, are too cumbersome to do. That people don't have enough time to do them, that they don't get reimbursed to do them, and therefore it becomes too challenging for them. And what I like to try and say to them is that if you consider a patient a candidate for anticoagulation therapy, with Coumadin, for example, that you're automatically going to ask them about their history. You're going to assess what the risk of them potentially taking this medication could be. You're going to discuss with them what things they will be able to do and what things they won't be able to do when they're on this medication. And you're also going to tell them that while they're on this medication, they're going to need to be very closely monitored from a laboratory perspective. If you overlay that on top of opioid prescribing, it's exactly the same thing. So in my mind, one of the things I would like healthcare providers on the front line to understand is that in that respect, chronic pain is no different than other medical conditions. You need to do exactly what you would do in almost all other cases. Where chronic pain is different from other medical conditions is that it's one of the very few situations where a patient gets to have a say in what a successful treatment outcome is. When you're treating someone for hypertension, you measure their blood pressure and you determine what range it falls into and whether that's a good range or not. Same thing with blood sugar, hemoglobin A1C, and everything else down the line. Patient just, in a very paternalistic way, gets told, we reached successful treatment outcome, or we're not quite there, we're going to make modifications, etc. In chronic pain, patient actually may have more of a say in what's a successful treatment outcome or not, because subjectively, they're going to relate to the healthcare provider whether or not their pain level has decreased, which is probably not the best thing to look for. Hopefully, they're going to relate to whether their functional capacity has improved or not. And basically, they're going to make a commentary about whether their overall quality of life has improved or not. That is a key differentiator. One other differentiator, I would say, is that there are many medical conditions where non-pharmacologic approaches are often the things that are tried first. Take hypertension. People will be told to go on a diet, to limit their amount of salt intake, do other things. Same things with diabetics or pre-diabetics. They'll be told to modify their diet, try and cut down the amount of sweets that they eat, maybe lose some weight, and then if those things don't work, then pharmacologic therapy may be employed. In chronic pain, it's exactly the opposite. Almost in every situation, even before the person seeks medical attention, there will be some kind of pharmacologic approaches that will be taken before seeking medical attention or will automatically be employed at the time that the person seeks medical attention. I think that's a real key difference. So there's almost no time that drugs aren't going to be involved in the initial phases of the treatment plan. I think that if I were going to analyze my perspective on where we've started and where we've come to with respect to pain being the fifth vital sign, I really would hope that people would start to think of it as a measure of functional capacity. And instead of asking people on a scale of 0 to 10, pain not impacting their lives or not being severe at all, or pain being as severe as it could be, I'd rather have that 0 to 10 scale be much more focused around how much does the pain you're experiencing inhibit your ability to do certain things in the course of a day, or do the things you need to do in the course of the day, and have it recalibrated to a functional capacity. And then we might be very less likely to hear people say 12 on a scale of 0 to 10. It's either it doesn't prevent me from doing anything I need to do, or I can't do anything I want to do, but there's nothing above that that people could say. It's somewhere in between those two. The 4 ethical principles that should guide people in terms of how they treat pain patients are not going to be impacted by guidelines. They're not going to be impacted by media attention. And they really are ways to root ways to treat patients throughout a clinical setting, throughout a healthcare system on a reproducible level. And those would be autonomy, non-maleficence, justice, and beneficence. I happen to consider autonomy to be number 1. No matter what happens, the patient gets to have a right to say yes or no in every single situation, or at least the proxy if they're not able to make their own decisions. Many people believe non-maleficence to be the overriding or overarching principle, which is do no harm, and is probably the one that most people are familiar with when they take the Hippocratic Oath. On the justice side, fits very well with the idea that no matter what you do, it must coincide with what the legal aspects dictate. And as guidelines change, and as the regulatory scrutiny increases, it's very important for healthcare providers to understand that they need to consider justice when they take into account the risk-benefit analysis and what they do to keep themselves out of trouble from a practice perspective. And then lastly is beneficence. What's most likely to benefit the patient? Every patient's going to be different. So what's going to benefit the patient is never going to be exactly the same. And balancing these 4 ethical principles and trying to mold them in every situation, knowing that in some cases, one may be overarching or overriding over the others in certain situations, and in other cases, another one of those principles may take precedence. That's okay. But no matter what happens, those 4 principles are rock solid, and they're not going to change. And in my mind, that's a good reproducible approach to managing patients with chronic pain, no matter what happens outside of them.